Good morning, everyone. I think we'll go ahead and get started. A few more people funneling in here. So my name is Karen Joint Maddox. I'm a cardiologist here, for those of you that I haven't met, and have the honor of co-directing our Center for Advancing Health Services Policy and Economics Research with Dr. Tim McBride, who's seated in the audience. It is my great honor this morning to co-host Grand Rounds in Vicki's absence, both on behalf of our center with Tim, as I mentioned, Kenton Johnston, our Associate Director for Research, and Abby Barker, our Associate Director for Policy Partnerships, along with our center manager, Kateri Chapman-Kramer. But I'm most honored to be able to play a small role in the first annual Dr. Sam and Rhoda Nussbaum lecture. And the Nussbaums are here with us in the front row. We're thrilled that you could be with us today. And I'm just very proud to be part of an opportunity to honor him, as well as to give all of you here the opportunity to learn a little bit about something that I know is very important to him, which is health policy. So I will introduce our introducer. So to introduce our speaker this morning is Dr. Steve Miller. So Dr. Miller previously served as Cigna's Chief Clinical Officer, and prior to that as Senior Vice President and Chief Medical Officer for Express Scripts. But most relevant to the present audience is both the husband of Vicki Frazier and prior Chief Medical Officer here at BJH. So has a long history with us here. He received his medical degree from UMKC, trained in pathology and medicine at UAB and in cardiology at UCSF, and got his MBA here at Olin. So we're thrilled to have him here today to introduce our speaker. So Dr. Miller.
Thanks, Karen, and thanks to everyone who's attending both in person and virtually. Today's Grand Rounds is really special in that it recognizes a couple who have been really instrumental to Washington University, BJC, the St. Louis community, and the nation at large. That couple is Sam and Rhoda Nussbaum. As Karen said, we're fortunate to have their three children here with us, Barry, Kara, and Jeff, and their niece, Lisa Shipley, who have all, in their own rights, have had tremendous careers and made great contributions. Vicki and I actually had the great fortune of coming into the Nussbaum sphere of interest almost about 25 years ago when Sam was recruited here to be from Harvard and Mass General, where he had a great academic career. Sam was recruited to be the first Executive Vice President and Chief Clinical Officer for BJC Health Systems. Sam was the one who truly established the link between Washington University physicians and BJC, but also with the physicians in the community at large. On top of that, he pursued an agenda of quality and safety and actually won a very prestigious National Quality Award for BJC Health System. But probably most importantly to Vicki and myself is Sam established with WashU a physician executive training program to get more doctors involved in administrative healthcare, because that's where the action was going to be if we were going to protect research, patient care, and education in the future. Sam eventually left BJC to become the Executive Vice President and Chief Clinical Officer for Anthem, one of the largest healthcare organizations in the world, and his influence spread, often being of great counsel to Congress, the White House, and others. And unfortunately, we lost Sam in September of 2021, but the Nussbaums never left St. Louis, even though he took on this national role. And he and Rhoda have contributed tremendously to our community. Rhoda through the Anti-Defamation League, World of Difference, their involvement with the Brown School at Washington University, the Institute of Public Health at Washington University, and probably many of you don't recognize it, but even our public parks are more beautiful because of the contributions they have made to beautify those settings. And so it's fitting today that our inaugural lecturer be Mark McClellan. Mark is probably the most trusted person in Washington, D.C. in healthcare policy by both Democrats and Republicans. Mark graduated from MIT with an economics degree. He then went on to Harvard to get both an MD and an MPH. He was a director. He was the commissioner of the FDA, I think, at the age of 14. He then went on to be the administrator at the Centers of Medicare and Medicaid, which is now CMS. And so Mark has accomplished more in his career than many of us. He's currently the Robert J. Margolis Professor of Business, Medicine, and Policy, and is the founding director of the Duke Margolis Center at Duke University. So there could be no one better to be the inaugural speaker. So Mark, the floor is yours. Thanks.
Thank you all. It's great to be here. I was telling Steve before we started that this is the first time he's ever had a chance to introduce me. I'm gonna have to remember that one. It was not quite 14 when I was at FDA, but I'm very pleased to be here with you all today. And it is it's such an honor for me to be the inaugural lecturer for the Nussbaum lecture for Sam and Rhoda. And I want to thank also Steve and Vicky for their support for this effort. There's several strands that come together at this Grand Rounds for me that personally mean a lot. One is the trends that the center here represents, the work on health services research and health policy, the coming plans for expanded public health activities here at WashU. I think we're in a uniquely good opportunity to reflect important trends in healthcare and public health, which is they're all coming together. And there's more that healthcare can do upstream than ever before. There's more that needs to do. That's not the way healthcare has traditionally been designed. And from a public health standpoint, we spent a lot of time during the pandemic, which the public health emergency officially ends tonight, seeing how there are gaps on the public health side, gaps on the healthcare side, in really improving population health, but some fundamental trends I think are reflected in the changing academic work and more integrated programs that are happening right here. I think you all are going to be a big part of leading these efforts, and it's great to see the centers relaunch as part of this next phase of how we approach health policy, health reform, and population health in the United States. And Sam was particularly relevant to these trends because he lived it. You heard from Steve a bit of a summary of Sam's own career trajectory, starting in clinical excellence, recognizing that excellence in the future required physicians, hospitals working more effectively together, and then his further career took him into how we pay for healthcare in the private sector. We're a public-private country, as most countries actually are, in figuring out how to improve the health of our population and deliver more effective therapies. And that's where I really got to know him in my time at CMS and subsequently when he was at WellPoint and Anthem. Received a lot of suggestions, some critical, but always delivered in that nice, friendly way that Sam had about what we should be doing in health policy. And that led to a friendship that has had continued for really the rest of Sam's life. I think the time near the end and in the midst of COVID, a time when we were all isolated, but as I'll talk about in a minute, Sam was still contributing nationally and globally to advancing this goal of better population health through the public and private sectors working together. So with that introduction, here's the, I guess, the usual WashU slide that has my disclosures. It's probably not even legible, but I would want to point out I'm a board member at Cigna, Alignment Healthcare, and Johnson & Johnson. That's in addition to work that I do, as I'll talk about, with the Healthcare Payment Learning and Action Network. I wanted to cover four main topics today. First is connecting Sam to all of the topics that I'm going to cover. Then talk about some of these trends in healthcare. Accountable care, is that a term that any residents have heard before? Yeah, not really. Okay, so it is coming. And I think if I describe it, you'll see how it's affecting some of the changes that are happening in healthcare financing and the way that care is delivered. There's some challenges in implementing this approach, which is really about accountability for the health of the populations you serve. So that encompasses accountability for handling admissions well, handling longitudinal care well, and meeting patients where they are to get the outcomes that that matter most to them. There's some real challenges in implementing these reforms in care and what has been as Sam often pointed out, a fee-for-service healthcare system that performs admirably in many ways, but leaves some gaps. One of those big gaps is involving specialists and thinking about the longitudinal care journey for patients. And I'll talk about a few more barriers here. So a good way to think about this would be around where we are and where we're headed in healthcare and some possible futures. And I want to try along the way to talk about how SAM fit into being a real force in the public and private sectors and here in St. Louis. About trying to move towards more effective population health and accountable care. This is a slide from a paper that I did with Karen Joint Maddox, among others, the American Heart Association, on sort of the state of American healthcare for cardiovascular disease. It's a little bit hard to read, but if you think about healthcare from the standpoint of a patient, it's really kind of a care and health journey that starts out with risk factors that are potentially identifiable and modifiable that haven't traditionally been the realm of health or medical care, proceeds to opportunities for diagnosing problems like hypertension, diabetes, prediabetes, other lipid disorders, other risk factors, smoking, modifiable risk factors, and then interventions to try starting at those early stages, and then as disease progresses, secondary and tertiary prevention to help improve that patient journey, slow down disease progression, intercept it, maybe even reverse it. And then further along the way, of course, we got some really impressive interventions to handle acute exacerbations of cardiovascular disease problems, whether it's ischemic disease and AMI or rhythm disorders. We've gotten much better at treating some of those downstream problems, even further downstream, congestive heart failure with LVADs and other interventions. And then at the end of life, of course, there's supportive care, palliative care, where there aren't any more interventions that matter. The challenge is that while we've got good medical technologies and a lot of increasingly good medical technologies at all of these stages and a lot of other supports, we haven't done a great job of routinely implementing them effectively for the whole diversity of the American population. And a lot of SAM's work, a lot of the work that we do at Duke Margolis, a lot of the work, probably fair to say, at the Center for Health Services Research and Policy is about how do you make this patient journey better? Because we've got so many people and so much resources along this journey trying so hard to help improve these outcomes that and well-being that matters to patients. This is just sort of a more generic version of the same thing. So patient journey, I know focused on cardiovascular disease, but this applies to a lot of medical risk factors. A couple of fundamental trends that are affecting how healthcare works on all of this, and this reflects a lot of discussions with Sam and his colleagues. Obviously, biotechnology and biomedical capabilities are changing. That goes at the for the right-hand side of this slide with more intensive interventions that require, that are more minimally invasive, that are digitally driven, AI assisted and the like, to do whether it's arrhythmia elimination or heart assistance more and more effectively with fewer and fewer side effects. But also, and perhaps even more notably from the long-term standpoint of patient health, earlier interventions to make more precise diagnosis of specific subtypes of cardiovascular disease or many other conditions possible upstream, where risk factors, genetic and otherwise, can be identified, where patients can be tracked using digital technologies and predicted using AI, machine learning, and big data to guide more precise diagnostic interventions and interceptions of disease progression. So I've talked some about cardiovascular disease, where we've got more effective treatments than ever, including potentially really impactful new drugs for diabetes, prediabetes, and obesity, and GLP-1s, and some of the other pathways involved. They're very well targeted. But this applies to just about any condition out there, earlier, more effective interventions that minimize the need for intensive downstream procedures and supports to manage complications. And the question is, how do we fit all this together more effectively? Since again, there are a lot of gaps. We've seen declines in population health in the United States, not just due to COVID, where even though we had the best treatments in the world, the soonest in the world, diagnostic tests, effective therapies, and safe and effective vaccines. We had well above average population mortality from COVID compared to the rest of the higher income world. But before and after the public health emergency, we've seen declining trends related to conditions like cardiovascular disease and life expectancy. So we're kind of not there yet on being able to apply these care models effectively. And one of the things that Sam and I used to talk a lot about was what's the easiest and best way to make it easier for, or to make it feasible for healthcare professionals who are really committed to making a difference in their patients' lives to change that trajectory. And Sam, along with many of us, are committed to trying to address some of the weaknesses of the way that we finance healthcare. So if you think about some of the traditional care models based on fee-for-service pricing that have focused on some of those downstream interventions with typically not as much support for diagnostic tests, preventive services, takes an act of Congress to add a preventive service to Medicare still. Prescription drugs took a major act of Congress that got me into CMS to implement this prescription drug benefit in 2004. And it was a time when prescriptions were already having a big impact on people's lives, even more so today and looking forward. We haven't done as much as we could to really promote those early interventions and upstream models that are well coordinated with the downstream care that people also need. So what I'm going to spend most of the rest of my time talking about is this move towards accountable care payments. And those are payments that are linked to people, not specific services, and linked to accountability for some of the improvements and steps along these individual patient journeys and journeys and experiences of whole populations of patients to try to achieve better outcomes without increasing total cost of care. And if you think about where we are today, many of these programs are being implemented, but we're not all the way there yet. Still, as I'll talk about, most of payments in fee-for-service models, still some of these gaps, but increasing attention and increasing opportunities thanks to that further progress in biomedical technology and digital technology supports to change all of that to more coordinated longitudinal care models, and try to talk a little bit about what that looks like too. So Sam had worked with me for really the last couple of decades on these issues since his time at BJC and his time in moving into the private sector to try to help these issues along. This is from a meeting that we had in China. He was part of a US-China bilateral collaboration on doing two things. One is advancing better public health and population health in both countries. And the second, given the challenges and the importance of US-China relationships for healthcare and public health, they're two countries that really determine, and in the years ahead are going to increasingly determine where the world goes in terms of biotechnology capabilities and support for global public health. Really important to have a dialogue, and this was outside of normal government channels with leaders in healthcare and public health from China, here in the United States too, to create more opportunities for ongoing collaboration, which when COVID-19 happened, were needed more than ever before. In the US, Sam helped launch an effort called the Healthcare Payment Learning and Action Network. It's actually a front slide from his presentation right after this whole effort started that he was giving in Washington, D.C. to explain what this effort was and why it was important. This is an effort funded by the Centers for Medicare and Medicaid Services, essentially to advance accountable care, as I was talking about before. And what does that mean? Well, this all sounds good, better care. Supporting care models that are centered on the person, that help where they're effective with earlier interventions, engaging people in care, bringing it to them upstream, spending better as a result by focusing on what matters most for the patient, not necessarily what's paid the best under traditional fee-for-service models. And with accountability is to have these changes in payment with more flexibility, more focus on the person to get to accountability around actually demonstrating improvements in population health and health equity. This didn't really fly over the political radar when these efforts started in 2015 and 2016, not because they weren't important, but because I think in some ways they were less politically controversial. So this effort actually got recognized by President Obama when it launched in 2015. As he said, what we have to do is change those best practices, to share best practices in healthcare, the good ideas, including the new ways to pay, again, more at the person level, accountable care, so that we're rewarding quality and rewarding better outcomes. And this is a public-private network, and who better do that than Sam to help make that happen. Secretary Burwell, Secretary of Health and Human Services at the time, actually came to the launch event with Sam, where he helped present all of this, talking about, again, accountable care is not a term that means anything to normal human beings, but if you're a provider involved in these care models, or a patient or business or a health plan, it's about building up that common interest. Or why are we really here? You know, it's not the procedures, doing them well is important. The visits, those are a great experience and those important. But why we're really here is because we want to help make patients' lives better. And the Learning and Action Network was intended to be a critical part of that. And this was started out being a lot about payment. And Sam was working for a major health insurer at the time that was trying to move payments in this direction to being more about outcomes. So a goal then of 2016, the year that we're starting, trying to get to 30% of payments, not in fee-for-service, but in these alternative models, 50% within a couple of years after that, with the idea that if the payments are about people, if we were supporting the providers through those payments and delivering these better care models, we would make more progress. And again, this wasn't a partisan issue. So you didn't hear about it on the nightly news so much because in the Trump administration came on board a lot of political controversies and new directions in some areas, but not this one. So it's Secretary Azar at HHS reaffirming another event with Sam very much involved that this change in payment, the change in the care delivery, this would support aiming to get to a personalized patient-centric health system, and that all payments really should move in this direction. So just to go a little bit deeper on what I mean here, it was a framework that Sam helped develop and helped publish, thinking about the way that we pay in healthcare. On the left-hand side of this chart, it's sort of fee-for-service, traditional payment, not directly linked to quality or value. A lot of healthcare providers have seen steps where people add like a bell or whistle to their fee-for-service payment. We'll pay you a little bit more, a little bit less if you show that you're following a certain process of care that's evidence-based, or if it's an admission, fewer readmissions. Those changes, it turns out, and Karen, I'm going to oversimplify, Tim, others oversimplify a lot of health service research, tended to get to better improvements in the measures. You check the box, maybe do a little bit better, but weren't really leading to fundamental changes in care redesign. Why not? Is you're not really changing the way that healthcare is supported. It's still kind of the same fee-for-service model. So over the last decade or two, there's been a lot more interest in the right-hand side of this chart, moving payments being based on people, not services. I remember one of my first meetings at CMS as administrator, and this was right after the Medicare Modernization Act had passed, a lot of attention on drug coverage and all that. It was with a number of leaders of healthcare systems who came in and said, look, we're trying to do person-centered care for our patients, investing in team-based approaches of care, electronic records, answering patients' emails, hiring staff who could visit our high-risk patients in the community, or pharmacists who could help them adhere to their medications and things like that. And we think it's leading to better outcomes. Here's some of the data. We think it's saving money for Medicare too, by the way, fewer admissions and the like, but we're losing money in doing all this because none of those things I just described at that point in history were being paid for by Medicare. We're paying for was the office visits, but not the upstream team-based supportive care and the emails being answered at home, not the care coordination services or the adherence services, all the kinds of things that Sam was trying to advance. So at that point in Medicare, we implemented the first version of what became known as accountable care, which was for these organizations. These are physician-led organizations and some health systems like Geisinger and Marshfield Clinic, others that, that you all may know. We would continue to pay them with the Medicare fee-for-service ways, but also we track how their patients were doing on some important population health outcomes like diabetes control, blood pressure control, measure their experience with care, and also how much we expected to pay out from Medicare for these patients. And the deal was, if the healthcare organizations who were accountable for these populations could get the cost down over time and show that they were also improving at least some of these dimensions of care, we'd pay them some of that difference in savings, so shared savings. So that's kind of a category 3 idea. It's still basically fee-for-service payment. Since then, we've seen a lot more movement towards category 4, which is, I think, about 2 payment tracks, one based on fee-for-service, one based on the person. More organizations have moved to person-based payments, diminishing the role of fee-for-service payments, giving them more funds that they can use as they think is most important, more flexibility in caring for patients, provided that they are improving outcomes that matter, improving dimensions of care that matter to patients, and lowering the total cost of care. That's sometimes called downside risk. It's not really about downside risk. That's kind of a consequence of having more resources tied to the person rather than tied to each specific service that you undertake. And essentially, that's a summary of where we are in, or what the alternative approaches to future of healthcare and financing in this country are right now. These payments linked to people, not services, go by the name of accountable care payments, because you're accountable for the results for a particular population of patients, and also for the resources used. There's also terminology in this space. Value-based care sometimes comes up. Value-based care can really mean anything. So prefer the term here, accountable care, because it's really defined in relation to payment and some other elements that I'll get to in just a minute. So the land did not hit its goals of getting to 30%, 50%, let alone 100% of payments. This is a survey that the land does every year for where healthcare payments are in the United States healthcare system. I think you could see from this that we're seeing incremental progress in moving to category 3 and category 4 models. By the way, the darker lines here are ones that involve bigger shifts away from fee-for-service, so not just shared savings, but some of that downside risk, organizations that are really moving away from linking their revenues, net revenues, and investments to fee-for-service payments. In terms of the categories of payments, we got different major payers in the United States. The light blue is Medicare, traditional Medicare. You can see there's been actually a lot of growth in these accountable care relationships in Medicare. Medicare Advantage is also in a blue shade here, the darker blue shade in the middle. Even more use in those programs. Remember, that's where Sam worked as in WellPoint, that was a leader in implementing many of these reforms over the last decade or so. Kind of a pause during COVID. What we saw then, just as a side note, was organizations that had moved into being paid more on a person basis than a fee-for-service basis actually did great in the pandemic, because when everybody else was facing this huge drop in their revenues in April 2020, when the shelter-in-place rules went into effect, people stopped going to the doctor, people stopped getting specialty procedures. It was a huge financial hit for hospitals and for many medical practices, just when we really needed them to step up. Now, CMS, the nation's largest public health agency, actually stepped in with flexibility in payments, and Congress passed some additional revenues for hospitals, and the hospitals and health systems flex very quickly to deliver more services at home, to move to alternative sites of care, to fill in some of those gaps. But those were temporary measures, and now that those public health funds have gone away, many hospitals and healthcare organizations are facing some tough financial situations this year, rising inflation, tight labor forces, whereas the organizations that had already moved away from fee-for-service, again, were kind of more stable in those environments. These organizations also had already implemented a lot of telehealth, home-based care, being able to identify their high-risk patients, both for, before the pandemic, it was for flu vaccines and monitoring their cardiovascular, respiratory conditions. Now, because they knew where they were and had the longitudinal data systems and the care teams in place, they could more easily reach out to them, engage them about vaccines, and get tests delivered to their home so that if they did have symptoms and tested positive, they could get quickly through telehealth help into test to treatment programs, things like that. But for most of healthcare, we're not yet in, at least not now, in those kinds of models. So why not? Why has this been hard? Well, part of it's, I think, connecting it with people and healthcare organizations that are trying to change, but are working under a lot of constraints. The Learning and Action Network, and Sam was involved in this before he died, was working on kind of updating our approach to describing the goals of accountable care. And, payment is really important. It's sort of like a necessary condition. If you can't sustain a model of care financially, it's hard to continue to do it. You think about like what you get paid for versus what really matters to patients. You want those two to line up. So payment matters a lot, but it's a means to an end. The goal here is the best achievable outcomes for everyone through equitable, comprehensive, high value, affordable, longitudinal care. And this is something that, I mentioned this being a bipartisan effort. Just this past year, the leadership of CMS, Secretary of HHS, President Biden reaffirmed that the goal for the Medicare and Medicaid programs is to get to accountable care for everyone in their programs. Everyone with Medicare, coordinated care, longitudinal care that focuses on their needs, that's paid for in this different way, and then includes some of these additional features. This is really critical for a second goal of the administration you've probably heard about a lot, which is improving health equity. Many of the contributors to inequities in healthcare aren't directly the health services themselves. Lack of access to health services is a real fact, even for people who have Medicare. Many people who have Medicare or Medicaid insurance, if they're from rural areas or underserved communities. But it's those pre-healthcare steps like transportation, having access to a visit at a time that works for you if you got one or two jobs, maybe with telehealth, which you might not easily have access to if you don't have broadband internet, or worrying about other issues in your daily life, food insecurity, housing insecurity. Those things aren't really medical care, but they are health care. And more steps to address health equity in these programs are moving care and helping physicians and healthcare organizations address those underlying issues too. The current administration and the private organizations working with it have dialed back the goals somewhat, but still are aiming to really accelerate progress in moving to these accountable care models over time. For those of you who are interested, this is all on the website. Just Google HCP LAN. This is kind of an expanded framework which recognizes that payment reform is important, but so are steps within organizations that can be challenging to undertake to implement data and infrastructure systems to be able to track patients longitudinally more effectively across sites of care. That's where interoperable clinical data and electronic medical records are supposed to be helpful, to implement quality improvement programs, to be able to measure quality in ways that matter, to get also reliable data on race, ethnicity, language, factors that are really correlated with differences, disparities in health outcomes and access to care, as I was just describing, and take steps to be accountable for all of those. As an example of this, if you're interested in thinking about it further, CMS just this past year launched a direct contracting model for healthcare providers in the United States who are interested, called ACO REACH. That's Accountable Care Organization, Realizing Equity, Access, and Community Health. not in there in the word or the words payment or downside risk, but that's underlying all of this. It's really about the more explicit focus on the goals of improving population outcomes and reducing health disparities, which again have been getting worse in the United States under our current financing and delivery systems. With the administration really viewing this as probably their best chance to address health equity by moving into these innovative models of care. I think there's been some criticism of the administration from their own Democratic progressive base for saying, well, these are approaches that involve, working with the private sector in new ways to make the investments needed to deliver these new care models. It takes new spending on new kinds of data infrastructure, new kinds of care teams, maybe ways to connect to people in the community, hiring community health workers. And there are a lot of private companies that are investing in these areas too, that are partnering with the healthcare providers, the hospitals, the physician groups that are implementing these models. But that kind of public-private partnership is really what U.S. healthcare is about under fee-for-service. Remember, our hospitals are not for profit, but still aiming to have positive net margins or revenues. And our physician practices, those are all mostly for profit to the extent they're still independent. They're all private. So public-private partnership and new ways of delivering care is really critical for supporting these reforms. And I think the current administration's work is an extension of the bipartisan efforts that people like Sam have helped to build out. So if you think about how this can be done in the United States today, there are a number of physician-led groups that are trying to take on more accountability for total cost of care. It's like, while primary care group is maybe 5% of healthcare spending, and what these organizations are essentially doing is saying, we can take steps through these kinds of investments if we get paid at the whole person level, and if we get, if we're accountable for achieving better outcomes and lower costs. It doesn't take that many admissions prevented or that many elective procedures that could be avoided through more effective earlier steps, population-based care models, to get total costs of care down and create a much better way of delivering care for our patients. ChenMed today has average primary care provider reimbursement that's twice the level of the national average, close to $300,000 per physician. They're accountable for some population risk. Their goal is to have none of their heart failure patients, for example, ever have an admission to the hospital. And they have to work in a different way as a quarterback of a team of healthcare providers that includes community health workers and other aides and the like. But they're able to, they're at a point now, they have very high physician satisfaction and waiting lists of primary care providers who want to join the program at a time when overall in healthcare, we're seeing a lot of burnout and a lot of challenges in patients, in providers feeling like they can work well in systems. On the hospital side, there are many hospital-based ACOs as well. These are organizations, including here, I think, where there's some movement into these accountable care arrangements, but still a lot of reliance on the traditional fee-for-service payment, especially for specialized care. There are also insurers that are becoming more integrated with care delivery and providing these comprehensive care models, and a number of private sector organizations that are working with traditional healthcare providers to augment their capabilities in delivering these kinds of services. And just looking at the clock, I want to highlight just a couple of ways in which you're probably seeing these different models developing right now around the country. So there have been a number of organizations that still rely primarily on fee-for-service. That's where most, but by no means all, and a declining amount of healthcare payments are directed today, where the hospital-based practices or organizations have acquired primary care physicians, multi-specialty practices, all integrated or at least consolidated into a larger system. Many of those systems still being based on fee-for-service payments are using the primary care groups as ways of bringing in more referrals and having a larger presence in the market. That's different from some of these advanced accountable care practices where the physician practices are driving potentially more of the care over time. Recently, you've seen hospital investments in this first model, but a number of other organizations investing in the second model. So Amazon Healthcare viewing the future of healthcare as moving more and more into the community, if not into the home. Recently purchased One Medical, which is a large group of more technology-enabled primary care practices. Walmart recently purchased Village MD, which is also a system of these kind of more increasingly advanced primary care organizations, CVS and Oak Street. So think of that as maybe an alternative, and again, I'm oversimplifying a bit, an alternative future for what healthcare could look like with much more of the focus of funding and care, because they're moving into accountable care models, being in the community at home in conjunction with using specialized care effectively. And what I think we're going to see over the next few years is maybe some continued conflicts and differences between these models, and a real question about how fast the kinds of reforms in payment that I described earlier are really going to accelerate versus how much healthcare organizations are going to continue to stay in the fee-for-service model of care that I described as well. Look for, I think we are kind of at an inflection point in these activities now that we're coming off the pandemic, and a lot of sense that the fee-for-service payments are continuing to tighten in Medicare, and I think in commercial payments systems as well are getting tougher to sustain the more traditional kinds of care models. And at the same time, technology, digital technologies, and biomedical innovations in terms of earlier, more accurate diagnostic capabilities and more targeted, sometimes intensive interventions, think like gene therapies, things like that, are coming to help people stay healthier and not progress as far down that care journey towards decline in function and end of life. Those fundamentals are on the side of these second types of models. But during your careers, for those of you who are residents now, you're going to see this play out. And while I think there are great opportunities for working and making a difference in people's lives in healthcare, just like Sam first told me when we met 20 years ago, Mark, you've got to do more to help make it easier to implement these care transformation models. I think he believes that that's where the future increasingly lies. I just want to finish up by saying there are some challenges to progress in these models. I especially want to focus on specialty care providers. That's 80% of spending in the U.S. healthcare system, much more than primary care. Much of what I talked about before is strengthening primary care. There are ways to support specialists as being, and they are absolutely critical in these models. Some specialists who are really good at procedures, really good at intensive treatments, need better support for just excellence in those care models. Frank Opelka, who's a leader with the American College of Surgeons, has developed a model for more episode payment that's not whole person, but that's for the whole set of services associated with a specialized procedure episode, to have smooth transitions in and out for those patients. And to support really sort of airline type systems of using lots of data to truly optimize care within those specialized care episodes. There are many hospitalist programs that are taking some important steps in this direction too, can fit right into these whole person care models. There also are many specialists, including nephrologists, who are providing the kind of comprehensive care already. They're just not getting paid for it for some patients with specialized conditions like advanced chronic kidney disease or end-stage renal disease. So payment models there are helping those kinds of specialists deliver more comprehensive care. And there are a lot of specialists who work with patients alongside primary care physicians and hopefully the increasingly, community-based care services to help patients have a better journey along their chronic disease pathway. Think cardiologists or endocrinologists or others. Right now, if you look at Medicare payments, most of them are tied to specific diagnostic services and procedures, especially elective ones for those specialties. And the way that many of these accountable care groups are working with those specialists is trying to find the ones that are most likely to help with curbside consults, co-management of patients, optimization of medications, taking steps outside of hospital admissions to help prevent those patients from progressing. I think about all the patients in the United States, for those who are involved in cardiology here, with atrial fibrillation that's not optimally controlled, congestive heart failure that's not optimally controlled, et cetera, et cetera. So you can think about care models that could work better there. It's just really hard for the specialists if they're not getting paid for those kinds of steps. So many of these accountable care organizations are working on per person payments for the specialists too, to support those kinds of care models. But these are all still areas with a lot of work in progress. The multi-payer alignment, something that Sam was really committed to do with the Healthcare Payment Learning and Action Network, is expanding to include close partnerships between CMS and private payers in multiple states, and more alignment of multi-payer models. CMS is about to announce another one next month, hopefully. It's hard for traditional healthcare organizations, understandably, to connect with social service organizations in dealing with these upstream factors. But we now have a lot of examples across states, including mine in North Carolina, where our main program with the federal government for Medicaid support now includes explicit support for building a statewide network for when healthcare providers find a patient who's got an unmet important social need that's getting in the way of their care experience, like food insecurity or housing issues or an unstable and unsafe environment at home, for direct referrals that are actually paid for by Medicaid to community organizations or social service organizations that can help that individual. So it's like accountable care that's including social service as well. And then in these payment models, what matters increasingly is not what the price for, say, a joint replacement is, or an elective cardiac procedure is, but how much does an organization that's caring for someone who is at higher risk because of having behavioral health conditions or other chronic conditions or frailty that leads to expected higher costs, expected worse outcomes, how much can we adjust payments to help those organizations attract and retain and deliver better care for those individuals? That's an issue that people here at WashU are working on as well. So these problems are not solved, but we are in the midst of this journey that Sam helped us start to lead, and that is a key part of where the future of U.S. healthcare might go. And I know Sam's not with us anymore to help us continue this journey directly, but he sure had a fundamental influence on all of us who are working towards these goals. So as you all think about, especially the residents and people who are just starting out, where your career might take you, what kind of healthcare organization, what your role in it might be. Steve started out by saying there are lots of opportunities for physicians who are willing to think about some of these financial issues and management and team redesign issues alongside excellence in clinical medicine. I'd say that's definitely true. There also are lots of opportunities for people who are delivering excellent specialized care and other important medical services, as well as our medical capabilities continue to expand. But hopefully, thanks to Sam's leadership, we're going to see more and more progress towards that whole person, coordinated care, those better longitudinal outcomes at the population level, better integration of healthcare with public health and population health goals. We're not there yet, but Sam certainly made a huge difference in enabling us to get there. I want to thank you for the opportunity to do a bit of a review of where we are, where we're headed on some of these fundamental issues that mattered so much to Sam. And I want to thank you in advance for everything that you all are doing. And very challenging environment for delivering excellent healthcare to make a difference in the lives of the American people. There's nothing more important than health. And I think that means there's nothing more important than trying to get all these issues right. And Sam would say there's eternal optimism. Look, we're not there yet, but we're sure going to keep trying. Thank you all very much for the opportunity.
Thank you. That was inspirational and it's a perfect way to honor Sam and to also hopefully encourage lots of people in this room and watching online to sort of join this work. We have some time for questions from the audience.
Thank you. That was a wonderful talk. I have wanted to ask specifically about specialty and subspecialty care in payments. So it's no secret that medical students and trainees are influenced, to put it mildly, by, as we all understand, the realities of living based on financial remuneration as they choose their, career goals. As a subspecialist within internal medicine, I'm probably one of the least paid positions out there. Me and all my colleagues, obviously. And if it were not for me being just weird, I think, as many of my medical colleagues have told me, you're just stupid. That's why you're going into this. I mean, I've actually had friends say that to me. What are we doing in real terms? So I think there's promise in the model approach, but the inherent problem seems to be, from where I sit at least, that yes, we embrace the model, but not everyone in the model is equally valued. And when I say value, value is tied to money. So you can give all the lip service you want in the world, but if you pay somebody who does a procedure that takes them 1 hour and it takes me 5 hours to dig through all the material in the literature so I can come up with a new model, a new treatment plan because we have run out of drugs to treat this person, then why should I go into the second one? So what are we doing to move that forward?
So great question for the people online. Just to summarize, from someone who is kind of on board with the direction that I was talking about now. So having a role and a career in internal medicine that's aligned with early intervention with patients, getting out in the community, spending more time with a patient based on what's appropriate, and working with people who other members of a care team. Which have not been well reimbursed, if reimbursed at all, under our traditional, kind of medical fee-for-service payment systems. And it seems like that's really hard to do. And many of your colleagues are kind of moving in the more traditional subspecialty care direction. And I think that's a reflection of kind of exactly where we are. I showed that slide earlier showing what share of US payments are going into some of these accountable care models, which are more at the person level and are typically associated with significantly higher payment rates overall for primary care physicians and significant shifts away from fee-for-service, incremental-based care. But encourage those of you who haven't seen some of the writings about it to look at what is happening at ChenMed. Chris Chen, who's the CEO there, recently wrote a book that describes this model and the experience of providers in it. Oak Street Health also said some writing about it. It's more viewed as more concierge care, but again, physicians not being paid on a just a per visit basis, but more on a per person basis. But that's still overall minority of total financing and therefore total care model support in the U.S. system. So I think you're going to see over the next few years, this continued tension and shift, pressures to shift in this direction, because this is what people really want: is care at home, care that's convenient, care that embraces abilities to influence their health outcomes and not move down that pathway more easily. Versus a lot of our traditional payment models being slow to move over. And keep watching on how much, programs like ACO REACH grows. That's 2 million Medicare beneficiaries now. That's a lot of people. Well, that's only a small fraction of the total number of Medicare beneficiaries. And altogether, these alternative payment models, even though they're relatively high uptake in the traditional Medicare program are only about 30% of all of Medicare payments. So the next few years is going to continue to be this tension. For people who are specialists out there, I wouldn't say don't do it. I would say think about how it can fit into a model like this. And if you were, we need excellent surgery. There's more that cancer care can do than ever before, but it's getting to be different. So, to take cancer therapies, we're getting better at there are way more diagnostic tests than there used to be. A lot of genomic testing that's underused, inappropriately used, and once patients have been diagnosed and what treatment they should get. In a few years, we're going to have blood-based cancer screening tests for a broader range of conditions. So linking that up with the appropriate therapy and then getting people through therapy efficiently. We can do chemotherapy infusions on an outpatient basis and manage the complications, keep those patients out of the hospital, which these care models are intended to support in oncology care are really important. And then the good news with cancer care, as just an example of a specialty that's doing really, really well, is that so many more people are surviving. The huge part of cancer care today is surveillance, sort of tertiary surveillance on survivors, where under our fee-for-service payment systems, a lot of those patients have to come all the way back to the oncology center to be seen and reimbursed by their provider and get follow-up screening and so forth there, rather than getting in their community with support from that provider. So again, in these specialty care areas, we need it more. We need it a lot because the technologies are getting better and better for specialized condition management, but the nature of that practice is changing. So I do think this is not going to happen overnight. You're going to have these tensions continuing for the next few years, maybe longer. But if you look at kind of the fundamentals here, I think we're arcing towards more early intervention and specialists that can be, and better examples of how specialists, primary care physicians, and a lot of other allied health professionals, as well as social service workers, can be integrated around these care models. But we're definitely not there yet. And as I say, as Sam would say, we're going to get there. We're going to keep working on it, and hopefully we can move faster through steps like the ones I talked about today. That's a really good question. It took a few minutes to answer.
Thank you for your talk. I have so many questions for you today, but just one. I know you hinted a bit, like with the change into accountable care models, we're also working on changing how we're reimbursing for payments. I was wondering if there were any concurrent changes related to like medical malpractice, tort reform, things like that. That would
yeah, it's a great question. So I talked a lot about payment. And the question was, well, there are other policies that are relevant to how clinicians are able to practice and how care gets organized. One of them is medical liability. And there, I haven't seen a whole lot of major changes. The number of malpractice liability law mainly occurs at the state level. And there have been some states that have adopted reforms where essentially you get more of a presumption in favor of providing good care if you're part of a system that's following evidence-based practice guidelines. You can show that you're, and these guidelines that lead to better outcomes were employed and were a fundamental part of your medical practice. So Maryland, other states have adopted some reforms in that kind of presumption direction. I don't know that our liability system has really fully kept up, but I do think that having systems of care that have better documentation, built in around why you treated a patient in a certain way and the connection to evidence, I think that does help in liability cases. But there's so many other regulations that matter here too. And we saw some of these come into play in the pandemic, site of service. So, if it's easier and better for a patient to get care, get an infusion on at a community center, or maybe even at home, lower complications, more convenient, maybe lower costs, we should move in that direction. There are a lot of flexibilities that did that in the pandemic, but more in a fee-for-service way. So you can do it in the hospital, you can do it at home, you get paid the same amount. When we did that, a lot of hospitals did move services out. That's not by itself really a model for saving money and having more resources to go somewhere else at the same time. So I'd like to see those flexibilities combined with, the ability of the organization to take some of those savings and move it into other aspects of, coordinated care. And I'd like to see some of that go back to keeping down our insurance premiums and making care more affordable as well. Scope of practice laws are a challenge in some cases. So finding ways to, and there are good examples of these model state legislation, also for telehealth laws. So a lot of regulations need to change to keep up with these models. And I think a good justification for them is that, when you're actually tracking outcomes for patients over time, you can show that, just because you're using a team-based approach to care, just because you're relying on telehealth, it's not actually making the outcomes worse. It can make them better. So again, something that very much in process and going to continue to be in process through the next few years of your career.
So thank you. I think in the interest of time, we'll have to stop. I'm sure if people have additional questions, you can just come up and visit. But thank you all for being here. Thank you, Mark, for being here. Thank you to the Nussbaum family and to Dr. Miller. And thank you all for being here this morning.